I just wanted to touch on Seli because in more detail, just in terms of the mechanism of XPO1 for everyone, because obviously this is an entirely novel target in myeloma, and I think it's recaptured our imagination as we've been able to really establish that selinexor can be given if you go low, go slow, as we say, in terms of dosing and schedule, and at the same time, particularly important in resistant disease. And I find it in my own practice helpful in my 17p deleted patients in combination in particular. So let's sort of pivot just to mechanism of action, just to remind everyone, obviously the nuclear export receptor pathway is critical in terms of resistance mechanisms in myeloma, and essentially is an attractive target in the context of malignant disease because of all of its downstream functions. And I think what's so important is to be aware of the variety of effects that inhibition of XPO1 can provide. And I think in terms of our constructs, well, just to touch on what we're going to focus on this morning, it's going to be selinexor as the first-in-class oral agent in this space. But I do want to emphasize that there's eltanexor as a next-generation small molecule that's being evaluated in a prospective fashion at the moment, and obviously we'll be very interested to see what happens. I think reflecting the preclinical work, Seli combined with steroid was obviously our first go-to in the context of combination therapy, recognizing all the limitations of that approach. But it's important to remember that Seli in itself upregulates sensitivity to glucocorticoid-mediated killing in myeloma. So the rationale was very strong, and obviously difficult as these patient population was to treat. They were all triple class refractory. This provided in the STORM study the evidence base for an accelerated approval. And obviously what then followed was the synergy with proteasome inhibition, which I think is incredibly important with XPO1 inhibition. And that provided the platform for the Boston study, which in the 1 to 3 prior exposed patients generated a significant evidence of clinical benefit such that it got full approval both by FDA and EMEA subsequently. And I think what's really interesting is its partnership with carfilzomib, and that's honestly where I personally in my own practice use selinexor a lot, is with carfilzomib-based therapy, recognizing that often patients have already had significant exposure to bortezomib earlier in their course. Now, what about clinical trial data? Well, let's go through this just to share with the group. This was obviously the STORM paper, which was published by Achai as the first author, and it was a privilege to be part of this study with Achai and others, which was in New England Journal, actually, back in 2019, just before the pandemic. And I think what's important to share here is this sort of consistent signal in heavily refractory patients. And just speaking organically, one of my patients had literally entered this study being refractory to every line of therapy. And this was the longest and most durable response he enjoyed on the doublet. Then when he subsequently progressed, actually, by that time, the drug was approved and we were able to actually switch him across to a combination strategy, and he responded again to that. But this was the only class of drug that he had a major response to, which I thought was fascinating. In any event, you can see the typical type of single-arm experience, which I think it's important not to undervalue, because I know we're all dealing in the era of 70% response rates from bispecifics and CAR-T, but oral agents like this with a consistent signal that provide a kind of real-world platform for us to use in the clinic really shouldn't be underestimated. Now, in terms of the Boston study, this was, I think, a courageous trial. I mean, what we did here was to say, okay, we've got the gold standard at that time, which was classically delivered bortezomib and dexamethasone as the control arm. Obviously has no place now, but back then it did. And the goal was to combine selinexor with bortezomib and dex, but to do so in a way that was more tolerable for patients, because I think we all recognize the challenges of the classically dosed selinexor regimen. So pivoting to Seli dosed weekly with bortezomib on a weekly schedule, which again was innovative because we were essentially downgrading the intensity of proteasome inhibition in the experimental arm. And I'm, again, very grateful that the FDA were able to were very comfortable actually with us pursuing that approach. And so what ultimately we ended up with was a triplet that outperformed the doublet, perhaps not surprisingly. But I think what really impressed people here was the implications in terms of cytogenetic risk on the one hand, in particular DEL17. And I think what is really striking to us as investigators in this trial was the impact on neuropathy. And the neuropathy rates were actually lower for the triplet compared to the doublet, reflecting, I think, the weekly schedule on the one hand. But on the other, this was an efficacious approach and really crystallized that you should be dosing selinexor once a week. So in terms of some of the subgroup analyses, just to sort of give you some of the additional efficacy outcomes and subgroups, which I think are so important, I just would say to the hub that I think understanding subgroups in myeloma is becoming increasingly important. Myeloma is not one disease, it's 100, if not more. And subgroup analysis, I think, becomes increasingly important as we think about prospective trial designs. In any event, if you look at the median overall survival signal, it's encouraging. Time to next therapy, DOR, all the clinical parameters of efficacy were favorable for the triplet arm, and the overall response rate similarly reflected this. Now, what about safety data? Well, I think we recognized in STORM very quickly that thrombocytopenia was a dominant side effect in terms of hematologic toxicity. Neutropenia is less common. It's about 20% or so in the grade 3 territory. I think what's more challenging for all of us with SELI is the non-heme toxicity. And in that regard, fatigue in particular, asthenia, nausea can be an issue, hyponatremia, these kinds of general side effects, which are important to know how to manage, with the nausea being, I think, one of the most important to get ahead of early. As you can see, adverse event dose modification interruption with STORM was almost, was 80%, reflecting the fact that moving to this weekly dosing schedule was critical. I think what's also important to note by way of comparison is our infection signal compared to antibody-based strategies and bispecifics and others was relatively low. And with that in mind, when you look at the Boston study here, the rates of PN were lower, importantly lower, and at the same time, especially for higher grade. And in that same context, we noticed that the incidence of certainly non-heme toxicity for the triplet was encouraging compared to what we'd seen with STORM. So I think a very important step forward with Boston. So what about real-world evidence? Now, I think this is an incredibly important area. And I think we're seeing it, I would argue, in a very striking fashion with the CAR-T experience, right? Beautifully conducted, highly well performed and curated studies for regulatory approval, generates fabulous data, and appropriately so. Real world translation becomes the challenge. And I think this is important to share with you, and this is why we wanted to focus on this for today, because there's, in many different agents, we see drop-offs. Examples are, which we don't see it, are daratumumab. We do not see a drop-off there. The real-world evidence is strongly supported or correlates with the clinical trials. Bortezomib, interesting, the same. Interestingly, carfilzomib not. There is a drop-off there. One of the biggest drop-offs we saw was with panabinostat, recognizing its tolerability issues. So this construct of what happens in the real world, what happens in the clinical trials is really important to grasp, because I think it gives us a real meaningful signal as to how these agents are translating to a benefit in the clinic for us on a day in, day out basis. So I want to touch on two experiences. One is actually led by the Greek team, and this is led by, again, Evangelos and his team, and Thanos, basically presented by Dr. Kastridis and published by him in just about a year or so ago. This is a retrospective analysis of around 44 patients. And basically what they were able to show, recognizing this is obviously a real world experience from Athens, reflects an academic input on it, but nonetheless, what you see here is a solid response rate consistent with the Boston study, and at the same time an adverse event profile which is very consistent, and importantly a PFS signal that's similar with a median OS that is also similar, recognizing cross-trial comparisons and experience always have to be approached with a caution. But dose reductions due to toxicity were still required in over half of the patients, so something to bear in mind. And as you look at the thrombocytopenia signal, very much what would have been expected together with the fatigue. The nausea, obviously, is one of our biggest challenges, as is hyponatremia. So that with consequent effects on mental status. So a lot to do here. And then in terms of GI toxicity, a signal that's real. So this real world data, I think, telling us where we have to think very hard about side effect management with selinexor. Right. So this in terms is more of analysis of a retrospective analysis of the outcomes from the same team. And I think it's very helpful. If you look at sicker patients, perhaps not surprisingly, they don't do so well. So something to bear in mind. And in the same time, whilst the outcomes were similar, it's very striking in this experience that the lower doses did not compromise efficacy. So I think that's really interesting. And I know, Hang, you've had some very interesting real world data from the Asia-Australia group looking at what happens to younger patients with toxicity versus older, and some striking findings which you might want to talk about in the discussion, because I think it's really interesting what you guys have observed. This is my understanding from Andrew and others. But at the same time, what you see here is a signal in the subgroups of interest, for example, high-risk cytogenetics and so forth. But I think what's so important is this lower dose doesn't compromise efficacy. In fact, it may enhance it. And because you manage toxicity, you enhance efficacy. And this is such an important strategy. Now, this obviously is a different experience from the UK. And Rakesh, I'm not sure, but you probably were part of this, I would imagine. Suffice to say, this was a look at a comparison of Celidex and CeliVD in heavily pretreated patients, relatively small numbers. So we have to be a little careful here, just 10 in the SVD group and 8 in the SD group. So just to be cautious here. But again, a heavily pretreated population, the response rate consistent with what the trials had suggested, and indeed the outcomes the same and the toxicity similar. But importantly, again, the message being the management of hyponatremia, nausea, and GI toxicity is key. Now, this I think is a very important area to touch on. Obviously, we've been so amazed by the impact of CAR T. It's been dramatic. And for those patients in whom it's successful, it's almost miraculous. And I think that's a consistent signal across all of the trials. Having said that, obviously, we've seen some challenges, and the importance of recognizing the value potentially of integrating prior selinexor exposure into outcomes with CAR T, and then in between immunotherapies, I think is really interesting. And I think what's very interesting in this data, and this was actually published now just this year, is that basically you're seeing the impact of selinexor have potential benefit on outcomes of CAR T, which may represent, in fact, an important effect on T cells and T cell health prior to engaging in CAR T. So best response to CAR T consistent with the fabulous data we're all familiar with, approaching 90%. What's interesting in terms of the exploratory multivariate analysis is the impact of selinexor on CAR T outcome. And interestingly also, some of the impacts on particularly difficult to treat subgroups, such as those patients with extramedullary disease. So what about safety profiles that we're discussing in terms of Seli? I just don't want to dwell on this for too long because I think we're very familiar with it, but the GI side effects are critical. So that's, I think, a key practice point for our community partners, is getting ahead of the GI toxicity rather than reacting to it, putting into place an antiemetic regimen which actually heads off these symptoms before they become established. Now, in terms of time of onset and involvement of selinexor-related AEs, I think this just emphasizes the point that I made, which is that essentially in getting ahead of side effects, it's important to be proactive rather than reactive, and that these side effects typically occur in the first 30 days of treatment. So I think at treatment initiation, going ahead with not only proactive antiemetic management immediately, but the use of Zyprexa and so on. We'll come into this in more detail at night. The use of fluid resuscitation in the clinic, recognizing for patients that can be an inconvenience, but may be very necessary. And doing that during the first phases of treatment may be important. So these are the practical considerations I wanted to quickly touch on. As I mentioned, the safety profile summarized here. I think one very interesting thing is we recognize that this drug crosses the blood-brain barrier. And I think that's fascinating. Now, everyone says, oh my goodness, isn't that a nightmare? And I would say, well, actually, whoa, guys, perhaps in our patients, I know Hang's nodding here a little bit, we see a lot of CNS disease these days, unfortunately a lot, but we see it. And I was actually, funny enough, Hang, just on a call last night with Georgia from St. Vincent's in Sydney, and she has an experience with Seli-Pom where she's seen activity in CNS disease from this combination. So, you know, just to remember that what looks like a bad side effect can actually be used for our advantage. And that being said, it's important to get ahead of the nausea and vomiting signal. In terms of the thrombocytopenia, again, the use of N-plate, as we use generously here in our clinic at Dana-Farber, is very appropriate, and similar agents can be helpful. It's clearly distinct from bortezomib-mediated thrombocytopenia and carfilzomib-mediated thrombocytopenia. I think the weekly dosing is essential. As we say, go low, go slow, and it really does make a big difference. We'll come to that in more detail. So how do we get ahead of this? Well, I think obviously, you know, ondansetron is key. I do want to make a big shout out for NK1 receptor antagonists. In the US, we have a Varubi brand, which is something to reach for quickly in my experience. It's a bit difficult with insurers sometimes, but it's worth the push because it doesn't interact in the same way with the metabolism of the drug as others do. And so in that context, it can be actually very useful. Steroids are a go-to and a must. Obviously, I mentioned the use of Zyprexa, just to be careful a little bit with EKG monitoring for QT in that setting. This, to me, is the most important. Hydration, hydration, hydration. Keep that serum sodium up. people feel better, and don't rely on them to drink, because they won't. So in that context, well, they will, but it won't be enough. So you need to supplement IV. So we often bring patients in for a couple of days of hydration, and it may sound inconvenient, but it's worth it, particularly early as they get settled into the routine. And basically in that context, we've also used local facilities to augment that, so patients don't have to come all the way to our center for it. In that context, there's been use of cannabinoids, which can sometimes be helpful. But in my experience, getting ahead of it is key. And obviously, just to stress to everyone, I think Saga said this best a long time ago, the best antiemetic for selinexor is bortezomib. If you combine it with a proteasome inhibitor and get a combination strategy going, it does so much better. And similarly for thrombocytopenia, appropriate management with romuplostin and others. This is again just a summary of toxicities and management strategies. And again, in the interest of time, I won't dwell on this. I know for sure all the members on the call are very familiar with these strategies, but obviously these will be shared on the website, so community practitioners and others can have access to it. Now, in terms of NCCN recommendations, it's worth sharing this. I think the NCCN do an amazing job, and this is another good example of it. Essentially, the NCCN recommendation is for combination strategies with selinexor, bortezomib, and dexamethasone, and selinexor and carfilzomib. I will stress that the combination with CD38 antibodies is also powerful. There's clear data for the combination with daratumumab from the STOMP study. I think that's an important thing to remember, and I would argue similarly with isatuximab, this strategy would be very reasonable, particularly as patients may have had DARA before. I think we touched on this before. The combination of selinexor with pomalidomide has really been very encouraging, and we use this often. In fact, we will even use selinexor, pomalidomide, bortezomib, and dex together in a 17p deleted patient. We did one recently in which I was able to on-ramp him with that platform to CAR T successfully, as one example. So these are sort of strategies that you can use. And similarly, of course, the classic combination of selinexor dex is what's approved, but let's please recognize the limitations of that approach. So these are my conclusions before discussion. Selinexor is an oral agent, small molecule, entirely non-cross-resistant with other strategies, and particularly, in my opinion, valuable in high-risk disease and extramedullary disease too, as well as those patients being engaged in immunotherapy, I think has a role. I think it's worth mentioning that if you have a low albumin and a high LDH, these patients warrant particular careful attention, especially when it comes to side effect management. In that context, getting ahead of GI side effects is clearly the goal, and being ahead of it rather than reactive is vital. Dose reduction is reasonable, but I tend to go low, i.e. 40, 60, and dose escalate very slowly on a weekly basis. There is a dose response, just to share with everyone, but I think that has to be approached with caution and clinical judgment. And personalized treatment strategies, obviously, we believe can enhance outcomes. Thank you very much. And I think we're just going to close on this to offer a paradigm for discussion for the panel, future directions, the use in earlier lines, especially in the context of 17B disease, which remains an enormous challenge for us. I think there's a terrific opportunity for selinexor to be integrated into CAR T and bispecifics in a very adjunctive and supportive way. And then also, of course, novel combinations. The next generation PI space is a little bit limited, unfortunately. I wish it was more generously filled. It really isn't beyond carfilzomib and bortezomib and perhaps to some extent ixazomib. But I think there's opportunities with combinations such as belantamab and others where this drug could potentially really have value. And just to close there and offer the floor to other members to discuss. Thank you, everyone.
Well, can I just make a comment on some of the things that you've said and perhaps shared my experience that you mentioned earlier about selinexor? So in Australia, we were very privileged to be able to participate initially in the STORM and then the Boston study, and then we had selinexor as compassionate access, and pretty much we echo everything that you've just mentioned. And that led actually to 2 clinical trials, investigator-initiated trials that we had the privilege to carry out with the support of Karyopharm. And in fact, one of those trials was the SEALAND study that was looking at selinexor as maintenance therapy post-stem cell transplant for transplant-eligible patients, comparing low-dose selinexor with lenalidomide versus lenalidomide. And I have to say that when I started in the first report of that trial, just as a trial in progress without any results, I got a lot of interesting feedback on Twitter, which I didn't respond to, but it was basically saying how terrible it was to use selinexor as maintenance therapy because of the known side effects. And indeed, what we did find, and I guess I can share the results here because the trial's now closed and we are going to report it. The bottom line is that it is a negative finding, but the reason why it's a negative finding is because these are young, fit people who wants to get back to their life and they just can't tolerate selinexor at moderate, even low dose. And the dose that we could only able to deliver was a 40 milligram dose. And in the end, after futility treatment, after about 190 patients got enrolled, there was very similar progression-free survival and overall survival with no separation of the curve at all. So I just thought I'd share that piece.
Yeah, and I appreciate it, Hank, because I think it's very important to understand the role of this drug in subgroups. I think this is the whole point. I mean, throwing the agent, any agent, at the wall and seeing which sort of sticks, to my mind, is challenging. I think, to my mind, the use of selinexor judiciously as part of a maintenance strategy with a proteasome inhibitor in a high-risk 17p deleted patient who you know is going to do bad things and already has EMD and is perhaps a VGPR at best post-intensification, that's the patient group. The other thing is, if you offer this drug to patients post-transplant, recovering mucosa, stem cell transplant with all the attendant long-term sequelae that will follow in a large group of patients, it's not surprising to me that you ran into tolerability issues that are probably greater than we've seen. So I applaud you. I mean, you don't answer questions unless you test them. And I think that study that you did was very reasonable. I'm sorry that you got such flack on Twitter because that's a difficult space to be scientific, I'm afraid. But it's a difficult place to be scientific. It's very easy to be rhetorical. It's quite different to be scientific. So I think in the context of exploring it, it's worth it. I personally would argue subgroups matter, and it's who you use it in. And funny enough, and this is an interesting thing, and I'd love your comments with your real-world Asia-Pacific experience. In the elderly, I found selinexor surprisingly better tolerated than I thought it would be, particularly at lower dose and using judicious things. And in those patients, they are higher risk. And the fact of the matter is, just because they're older doesn't actually mean that they don't actually tolerate it very well. And this particular gentleman, Storm, who just took my breath away in terms of his response, I mean, he was a septuagenarian, actually just becoming an octogenarian when we started, and he did remarkably well. So, Hang, do you want to comment on that with your Asia real-world experience?
Absolutely. We found the same thing. And we don't know whether it's a biological thing or whether it is the fact that elderly patients just generally cope with things better because they're not functioning, they don't go out, they don't have a job to carry on, and they just generally have they're used to the way they're feeling. I don't know. But that is exactly true. And in fact, to further your comment, there is a subgroup of patients we found for some reason tolerate selinexor incredibly well, to the point that they can tolerate 100 milligram quite easily without any serious side effects. And those are the patients who do very, very well. We had, in fact, based on that experience, I had a patient with CNS lymphoma who we ended up going into sufficient remission with selinexor and POM and DEX, albeit with some intrathecals, to the point that he could be bridged to another clinical trial when it was all cleared. And so based on that, we also developed another investigation-initiated studies looking at orphan groups of patients. So we're looking at patients with CNS disease, extramedullary disease, renal impairment, so all the patients that can't get into clinical trials in whom selinexor would help. So that trial's currently closed, but we will be reporting just on the preliminary results of those trials.
And Georgia shared with me, because I actually have a CNS patient who's just, I mean, she's actually in VGPR to everything, but she's now remarkably developed a right frontal lobe, but slightly posterior plasmacytoma within the parenchyma of her brain. And Georgia was saying, why don't you think about the use of Seli-Pom-Dex in her? I mean, the point is, it was an excellent suggestion, because she mentioned that she had some CNS responders in that trial that you're talking about, I think. Correct me if I'm wrong. Yeah,
Yes,
so it's actually
yes.
a great suggestion because it does cross the brain barrier, of course, as does POM, and we really don't have effective agents outside of radiation therapy for truly parenchymal CNS disease, which for whatever reason we are seeing more of it. Thank you, Hang. That's wonderful. I just want to. We've just got maybe a couple more minutes, so I just want to make sure Rakesh, others, Morie, other folks on the call, if anyone has comments they'd like to make, we'd welcome them.
I've used it in bridging. A lot of patients come referred to Mayo for some form of targeted immunotherapy. And if we select CAR T and they have aggressive disease that isn't going to be stable, it's very common for these patients to come and exhausted IMiDs and PIs and anti-CD38. And actually, we use cyclophosphamide and selinexor as our bridging. And even if there's issues with the anorexia and the weight loss, we're talking 6 weeks of therapy trying to keep the lid on the myeloma before things explode. And you can usually coach them through, even if it's producing significant decline in performance status related to the anorexia and asthenia.
Well, very interesting, Morie, because how do you handle the sodium with this high dose? We're using what, intermediate dose Cytoxan IV? I mean, how are you doing that? Because serum.
So we'll use 500 milligrams orally once a week, or we'll use 1.5 grams per meter squared every 3 weeks IV, and electrolytes are generally not a problem.
That's very interesting. Well, we've had great experience in the same way with on-ramping. We haven't used cyclophosphamide, to be honest with you. We've tended to stay away simply because we anticipated overlapping non-heme tox. But to your point, that's very interesting. I will just share one last thing. We've got an ongoing arm led by my colleague Clifton Moe of selinexor, mezigdomide, and dex. And I had a patient I brought into that study preparing him for CAR T, and he had highly refractory disease. He's had a CR to selimezi-dex. And he said to me, Paul, I'm in no rush for my CAR T. Let's take a break. I'm going to enjoy this for as long as I can, to your point. But we've got him teed up for a CAR T as and when the time comes. So excellent comment, Morie. I noticed, I think we've got other people on the call. I see Mary V's joined us. Mary V, do you have any comments to add?
I don't know if you commented, some experiments that are ongoing trying to demonstrate how selinexor can express BCMA on the surface of the plasma cells. This will be of great help in order to sequence BCMA targeted therapy. I don't know if you have commented something on this, Paul.
Mary V, that's brilliant. I did touch earlier on the fact that celi exposure prior to CAR T enhanced response. So what you've said provides a beautiful rationale for that. So thank you for that. I appreciate it.